Recording in progress.
Ms. Stevie Carter is a sleep medicine physician assistant at Johns Hopkins Community Physicians. Her clinical background includes internal medicine and geriatric psychiatry. She has also worked in clinical research, most notably with several COVID-19 vaccine candidates during the COVID-19 pandemic. Ms. Carter's approach to medicine integrates both the physical and mental health of patients to identify and treat sleep disorders, with an emphasis on developing strong relationships in order to provide patient-centered care. In her spare time, she enjoys singing in a local choir, exploring new cuisines, and spending time outside with her family. Without further ado, I'm honored to present Ms. Stevie Carter.
Hello, everyone. Thank you for that introduction. So I had a quick slide with that information on it, but you already introduced me, so let's just jump right into the topic. So, sleep, why is it important? I would challenge those of you listening to ask yourselves if you got more than 7 hours of sleep last night. So we spend a third of our lives sleeping and every second of our lives breathing, but millions of people struggle with one or both every single night. So my goal is that you leave today with a clearer understanding of what healthy sleep is and how you breathe at nighttime can make or break your sleep quality and your overall health. So, why does sleep matter? We are a sleep-deprived culture. A third of adults in the US sleep less than 7 hours nightly. There is a huge economic cost associated with lack of sleep. The cost of insomnia is between $92.5 to $107.5 billion annually. The economic cost of sleep apnea is $15.9 billion annually, and that was in the year 2000, so it is probably higher now. Not only that, sleeping less than 7 hours per night is associated with a lot of health issues to include risk of obesity, diabetes, high blood pressure, coronary artery disease, stroke, mental health issues, and all-cause mortality, in other words, death. It also leads to higher incidences of motor vehicle accidents, so less than 7 hours of sleep. 6 hours of sleep gives you a 1.3 times higher risk of a car crash, and less than 4 hours elevates that risk to 15.1 times. Federal data suggests that between 15 to 33% of fatal crashes are due to sleepiness while driving. And this is older data, but in 2004, 17% of Americans self-reported falling asleep behind the wheel. Oop. Sorry about that. So, what is sleep? It is a reversible behavioral state that is characterized by a decreased responsiveness to the environment. That is straight from a gerontology textbook. It is, however, an active and organized state, which we're going to talk about a little bit in the slides to come. Why do we sleep? There are still a lot of unknowns regarding why and how sleep works. What we know is that it is used for maintenance and repair. We heal tissue, we recharge the immune system, memory consolidation occurs. That's where temporary memory becomes long-term memory. And so what triggers sleep? Why do we get tired? We've all probably heard of melatonin, seen it on the shelf at the store. It is actually naturally produced in the brain and responds to darkness. Darkness is the sleep signal. Levels rise in the evening, peak during the night, and they fall by morning. And how much sleep do we need? I have narrowed these age ranges down to the ages in which I have more clinical experience. And these recommendations are from the National Sleep Foundation. However, you will see a wider range for what is considered normal. For example, teens' normal range is 7 to 11 hours, young adults 6 to 11 hours, 25 to 64 years old adults 6 to 10 hours, and then 65 plus years old 5 to 9 hours. So I'm going to go a little bit into what sleep stages are, what's happening during sleep. Sleep stages are the different phases your brain and body cycle through each night. It happens about every 90 to 120 minutes, and each stage has a job. So, light sleep includes stage one and stage two sleep. Stage one sleep is your sleep wake transition period. You might feel awake, but are actually in very light sleep. It's about 5% of the night. Stage two is where the heart rate slows, your body temperature drops, and you get protection from external stimuli. This is to avoid you waking up as you dive deeper into the deeper stages of sleep. Um, Stage two is 45 to 50% of the night. Stage three, or deep sleep, is where the body repairs itself. You get an immune system boost. That's about 20-25% of sleep. And rapid eye movement sleep, or REM, is where you have memory consolidation, there's learning and emotional processing. That's 20 to 25% of the night. And here is what we call a hypnogram. It is showing what happens in terms of sleep staging over the course of the night. Your vertical axis to the left, you'll see the W is for awake, R for REM, and then stage one, stage two, stage three going down. Left to right is over time, and you can see very clearly those 90 to 120 minute cycles. I'll also point out that stage three sleep tends to progressively decrease as the night goes on, and REM sleep tends to progressively increase, making the second half of your night heavier in REM. So, sleep and aging. This one has a lot of unknowns attached to it. We know that there's a reduction in sleep efficiency with age. Sleep efficiency is the calculation of time asleep divided by time in bed expressed as a percent. And it takes longer to fall asleep. We think that it is illness plus aging that leads to disrupted sleep. When you compare healthy older adults to adults with chronic illness, healthy adults are less likely to fall asleep during nap opportunities, which overall indicates less sleepiness. We think that maybe there is a decreased ability to sleep rather than a decreased need for sleep, but again, there are still a lot of unknowns. And overall, just age-related changes in the body. Um, there are neurotransmitter changes, structural brain changes. The internal clock that's responsible for your sleep-wake cycle starts to weaken. And even the eyes let in less light, which can disrupt how melatonin is produced. So first, I'm going to go over some things within our power to help with nighttime sleep. And then after that, I'm going to discuss a little bit of how breathing can interrupt that. So firstly here, sleep hygiene. If you haven't heard this term before, I use it all the time with patients. It is how you sleep better. It's the things that you do in order to sleep better. And the first thing I want to emphasize is that light is a drug, and its job is to keep you awake. If you remember, melatonin is related to darkness as the sleep signal. It is suppressed whenever you expose your eyes to light. So I have patients avoid it within the 2 hours before bed and augment it in the morning. Sunlight upon waking, if it's that time of year where it is not very bright in the morning or when you need to be up, a light box is adequate. I also have patients utilize smart technology. You can get smart bulbs for pretty cheap these days. You can dim and warm them before bed to darken things and not disrupt that melatonin production. And I also have patients use them as a sunrise alarm in the morning. Preferably, we're not on electronics within a couple of hours of bedtime or in the middle of the night, but I also live in the real world and don't always take my own advice. And so there are blue light filters on most operating systems now. Apple has them, Android, Windows, Mac. And I have patients schedule them 2 hours before bed and crank the warmness as warm as you can take it. If you open one up on your phone, you'll see if you make the setting more warm, it'll make your screen more orange. In terms of blue blocking glasses or even just orange safety glasses, which help block blue light, There's limited data, but I have had patients benefit from this who have sleep onset insomnia or if they have to get up in the middle of the night. Um, and it's pretty low risk. It's not going to hurt anything to try it. Um, Also, we should consider schedule consistency. So it's important to know that your sleep-wake cycle or circadian rhythm, it's driven by your wake time. A lot of patients will think, oh, if I go to bed earlier, I will sleep earlier. But your brain counts down about 16 hours from the wake time to when it needs to be tired. So if you have a consistent schedule, it helps lock things in and cause fewer sleep disruptions. So don't sleep in more than 1 to 2 hours on off days. Have a calming bedtime routine, dim the lighting, like I said earlier, have a warm shower, a bath, and anything else that will help you wind down. Also consider behavioral and environmental factors. The bed is for sleep and sex. I tell patients don't be on your phone in bed, don't watch TV in bed. Your brain's going to start associating bed with other things than sleep. No caffeine within 4 to 6 hours of bedtime. The half-life of caffeine is about 6 hours. Some people are more sensitive and less sensitive. You probably know which category you fall in and can adjust accordingly. Um, Within 3 hours of bedtime, we shouldn't have nicotine, alcohol, or large meals. Emphasizing the large meals, it is a digestion is a wake promoting process. It will wake you up, and alcohol disrupts REM sleep. So you may recall at some point in your life, if you consume alcohol, that you might get to sleep fine after drinking, but wake up a lot in the early morning. Try to engage only in relaxing activities 1 to 2 hours before bedtime. So don't go training for a marathon within an hour of bed. And then avoiding long naps. I tell patients, preferably not more than 20 minutes. You can convince me to stretch it to 30 minutes within 6 hours of bedtime. So, what if you're doing everything right and you're still having trouble sleeping? It could be your breathing that is contributing to the problem. So, when we consider sleep disordered breathing, broadly, there are two categories: obstructive sleep apnea and central sleep apnea. Obstructive sleep apnea is going to be my topic today in terms of breathing. In obstructive sleep apnea, the signal to breathe is sent. The airway closes or partially closes repeatedly throughout the night. While in central sleep apnea, the signal to breathe is not sent. I like to compare it to computers. So obstructive sleep apnea is kind of a hardware issue, while central sleep apnea is a software issue. So who's diagnosed with sleep apnea? In the US, up to 25% of adults. When you split it by sex, 34% and 17% of middle-aged men and women. Generally, men have 2 times the risk of sleep apnea as compared to women. But when you start breaking that up into age groups, ages 30 to 49, 26.6% of men and 8.7% of women. And then ages 50 to 70, 43.2% of men and 27.8% of women. I want you to tuck in the back of your brain that large increase in the percentage of women who have sleep apnea between those age groups. We're going to come back to that later. There are risk factors for sleep apnea. Chief among them is a small airway. If you have a short, large neck, or also a long, thin neck, if you have a willowy kind of body build, large tonsils, if you have a low-lying soft palate and uvula, a large tongue, those are all risk factors. You crowd the airway more, it's more likely to have blockages. Genetics plays a role, family history. If your parents have sleep apnea, your odds of having it are higher. We don't completely understand how that works, but we're working on it. And then being older than 50 years old is a risk factor. As we age, we do have decreased muscle tone. That decreased muscle tone extends to the airway and makes it more likely to collapse. And menopause. So postmenopausal women are at about a 2.5 to 3.5 times higher risk of sleep apnea when compared to premenopausal women, and they're nearly equal to risk of sleep apnea compared to men. They catch up with men postmenopause. Also, postmenopausal women have atypical sleep apnea symptoms. They tend to have primary complaints of insomnia, daytime fatigue, as well as cognitive complaints. These are all symptoms that are also often attributed just to menopause, so it becomes much more nuanced in those cases. So, how obstructive sleep apnea works, we can divide this into the anatomy and muscle tone of the airway. How much room is there, and how well does the airway stay open? Both of these are examples of obstructive sleep apnea. They're different kinds of disordered breathing events. Apologies, I live next to a main road and there is a fire engine driving by. So on the left, you can see this is a view of a person from the right or from the side, and you can see that the airway there is partially blocked, leading to disrupted airflow. On the right, it's completely blocked. And uh, this happens repetitively throughout the night in obstructive sleep apnea. We also consider, why does sleep apnea cause the health issues that it does? Firstly, your body goes into fight or flight. Your brain doesn't like sleep apnea. It doesn't like the lack of oxygen nor the disordered breathing events. I always use the example of a tiger chasing you with my patients. If you're being chased by a tiger, there are a cascade of things that happen in the brain and body to try to keep you alive. So there's stress hormone release, your body dumps blood sugar into the bloodstream, and a number of other things. The problem is we're not being chased by tigers. We're not breathing adequately. And we'll go into how that affects the different kinds of risks associated with sleep apnea. Sleep fragmentation also disrupts memory, storage, and tissue healing. And then the changes in chest pressure with these disordered breathing events also contribute to the health risks. If you think about covering your nose and mouth and trying to breathe against that, you can feel that chest pressure change. And it's that negative intrathoracic pressure swing that can contribute to issues. So firstly, we're going to talk about heart health. Hypertension or high blood pressure, you have a twofold risk of it if you have sleep apnea. 30 to 50% of hypertension patients have sleep apnea, and up to 80% of treatment-resistant hypertension patients. Why does that happen? The surge of adrenaline causes blood vessels to tighten, and it causes blood pressure spikes. So your body kind of stays in high alert, and your blood pressure stays elevated even into the daytime. For a coronary artery disease, you get drops in oxygen and surges in adrenaline that cause small injuries to the inner lining of the blood vessels throughout the body, including those in the heart. And over time, this leads to inflammation that causes fatty deposits to build up, and then those vessels are gradually narrowed. And when one of those deposits breaks open, a blood clot blocks the artery, and that causes a heart attack. So a twofold risk of coronary artery disease. Atrial fibrillation, if you don't know, it's a type of heart rhythm issue where the heart misfires, and sleep apnea contributes to it heavily. There's a fivefold risk. 76 to 85% of AFib patients have sleep apnea, and there is an 82% recurrence if it's left untreated. Again, I keep talking about surges of adrenaline, but you have a surge of adrenaline, the heart is starved of oxygen, and those chest pressure changes. These all contribute to inflammation. It stretches the heart and makes it start to fire incorrectly. From a brain health perspective, there is a risk of stroke. So 71% of post-stroke patients are diagnosed with sleep apnea. The mechanism of action is similar to heart attacks and coronary artery disease. Those oxygen drops cause injuries to the vessels. That promotes inflammation, makes the blood more likely to clot. And also swings in blood pressure they place extra stress on those vessels, which also make them more prone to blockage or rupture. And sleep apnea is not only an independent risk factor for stroke, but also for whether or not a patient will have another stroke, risk factor for overall death, and functional and cognitive outcomes. In other words, whether or not you as a patient can use your mind and body after your stroke like you did before your stroke. There is a higher risk of dementia and cognitive dysfunction with obstructive sleep apnea, 34% increased risk overall. The stress leads to brain inflammation, and low quality sleep leads to the brain not cleaning itself out at nighttime, and that causes a buildup of the proteins that contribute to dementia. I'll point out here that people with sleep apnea, they may look like they're developing dementia or cognitive issues, and I have seen it where when it is treated and the patient is getting adequate sleep and oxygen at night, those cognitive complaints can improve. The Parkinson's disease connection is probably the most recent of all of the ones I've listed. Um, there was a study published in the Journal of the American Medical Association Neurology magazine in January, or journal in January of 2026. So this year, they reviewed over 20 years of data and over 11 million charts with the Department of Veterans Affairs. And they found a twofold risk for Parkinson's disease. We don't understand why. They don't understand why. More studies are needed to figure out why. From a mental health perspective, insomnia, 30 to 50% of sleep apnea patients have insomnia. And sleep apnea also contributes to mood issues such as depression and anxiety. Twofold risk of depression, 66% higher risk of anxiety. There are elevated stress hormones, there's disrupted sleep. That disrupted sleep causes emotional regulation issues, memory consolidation is interrupted, and that increases depression, anxiety, irritability, and concentration issues. There's also damage to the nerve circuits that regulate mood. And then, furthermore, from a mental health perspective, up to 95% of sleep apnea patients report memory or attentional deficits. And from an ADHD perspective, there are numbers out there to suggest as much as 50% of sleep apnea patients have comorbid ADHD, or they have ADHD as a diagnosis. And 20 to 30% of ADHD patients may have obstructive sleep apnea. When it is treated, it improves behavior and inattention and overall symptoms of ADHD. And from a metabolic health perspective, there's a twofold risk of type 2 diabetes. Again, back to the stress hormones. They're released and cause stored sugar to be released into the bloodstream. If you remember the tiger analogy from earlier, if you're being chased by a tiger, you need energy to run, and your body is trying to provide that energy by dumping sugar into your bloodstream. The problem is this is happening over and over, and you're not using that sugar, and your body cells stop responding to insulin, which is responsible for retrieving that sugar and storing it. And over time, that resistance, that insulin resistance, plus the inflammation from oxygen drops, makes blood sugar control more difficult, and that leads to type 2 diabetes. Weight gain there's a bidirectional relationship. So a 10% weight gain can cause up to 32% more breathing interruptions per hour of sleep. Your body produces more of the hunger hormone and less of the hormone that tells you you're full when you have untreated sleep apnea. The oxygen drops and stress hormones trigger your fat cells to release fatty acids, but they're not burned for energy. Instead, they end up being stored in the belly and around internal organs, places we don't necessarily want them. And then the fragmented sleep shifts your body's metabolism to burn more carbohydrates and less fat. So fat tends to accumulate even when calorie intake stays the same. And from a gastrointestinal health perspective, there is a twofold risk of fatty liver disease with untreated sleep apnea and increased esophageal reflux. In other words, heartburn, acid reflux. There's a 2 to 3-fold risk of Barrett's esophagus, which is a precursor to esophageal cancer. And the reflux is specifically because of the changes in chest pressure. That negative chest pressure causes the stomach acid to splash back up into the esophagus, and over time it damages those cells. So it's worth noting many of these risks overlap with the risks of inadequate amount of sleep that I mentioned earlier, and there's interplay between them. If you get too little sleep, that can lead to weight gain. That can lead then to obstructive sleep apnea, which then interrupts your sleep. Too little or poor quality sleep, and things just kind of snowball from there. So, why am I highlighting the risks of apnea? I want to emphasize how very important it is that if you suspect you have it, it needs to be evaluated, and if it's present, it needs to be treated. So on this slide, I have a list of reasons to see a healthcare provider. One, persistent insomnia lasting more than 3 months, especially if you have frequent awakenings. It's worth noting that 50 to 60% of sleep apnea patients wake up 2 or more times a night to urinate. And a lot of times they think that's the only reason they're waking up. And the real reason is the breathing is interrupting their sleep. Their brain wakes up to try to open the airway, and that'll knock them out of sleep. But they don't realize that's the reason. And so then the first thing we all think about when we wake up in the middle of the night is, do I need to urinate? And so these patients will often think they have a urinary issue. They treat the sleep apnea, and the nighttime bathroom breaks reduce or stop. Um, Excessive daytime sleepiness, loud snoring, waking up gasping or choking, witnessed breathing pauses at nighttime, waking unrefreshed, morning headaches, unexplained high blood pressure, and new or recurrent atrial fibrillation. So I know that all kind of sounds like doom and gloom, but I'm going to give you a little hope on the next slide. This is an extremely treatable condition. Very, very, very treatable. So CPAP, you may have heard of it, continuous positive airway pressure. It's the first line treatment. It's over 90% effective. In some data suggests 96 to 100% effective. If you wear the CPAP machine and are able to tolerate it, it will almost always work. There are dental appliances for sleep apnea. They work by moving the low jaw a little bit forward when you wear it at nighttime, and that pulls some of the flesh off of the back of the airway. It works in mild to moderate sleep apnea as long as you don't have significant oxygen drops. Weight loss can also improve the overall degree of apnea. 10% weight loss can yield a 25+% improvement in apnea. And Zepbound got the FDA approval for treating sleep apnea. It's one of the GLP-1 drugs like Ozempic and Wegovy and all of those you've heard about. And then at the end of the day, there are also hypoglossal nerve stimulators. You may have seen commercials for them on TV, mainly Inspire, but Genio is a newer one as well. They're effective as long as the apnea is not significantly severe, and there is a BMI or weight limit on whether or not having that surgically implanted is indicated. I like to highlight that I love treating obstructive sleep apnea because it's so treatable. And it significantly changes patients' lives for the better. When you get the sleep improved, everything else just kind of ties together. It's very rewarding as a provider. So, with all of that, that's the end of the presentation. I'd open the floor for questions here.
Thank you, Ms. Carter, for that very informative presentation. We'll now begin the Q&A portion of the webinar. Our first question comes from Christine, who asked, once when I sleepwalked, my doctor said we are usually paralyzed during sleep. Is that true?
Depends on the stage of sleep. So, the paralysis is seen in REM sleep. Technically, we dream the most in REM sleep. And the example I use is we don't want to go walking around during our dreams. And so, REM sleep, 20 to 25% of the night is spent paralyzed. Ideally, there are disorders in which you are not paralyzed and people do act out their dreams, but also sleepwalking can occur in non-REM sleep, which are all of the other stages that I talked about that don't include REM. Did that answer the question?
Yes, I believe so. Thank you very much. Our next question comes from Dave. I find medications, particularly mix of medications, can affect sleep both ways, more sleep and less sleep. Meds have warnings about influence on sleep, but not on mixing with other meds. Any solutions for this?
Solutions. So I'm guessing the question is being asked is taking multiple medications and their effects on sleep. Yeah, it
Yes,
becomes. Oh, sorry.
yes, I'm sorry. Yes, from what I gather, I think he's asking without specific guidance, like if you weren't given specific guidance, like from your physician on mixing different medications. That's how I read his question. Do you have any suggestions?
I would say my number one suggestion, more broadly in medicine, is always trying to avoid what we call polypharmacy, which is taking multiple medications because you start to get more side effects. And that polypharmacy, yeah, it can extend to sleep. There are medications that disrupt your sleep architecture at nighttime. The sleep architecture is how you cycle through what sleep stages and how long you spend in each of those, as well as despite decreasing, say, stage 3 or REM sleep, they can also make you feel sedated in the daytime. And so, yeah, there can be additive side effects from multiple meds. I would challenge patients to be sure and talk with primary care, make sure everything you're on is needed and necessary. And from there, if sleep is interrupted or daytime sedation is experienced, that's when to talk to a sleep medicine provider.
Our next question. I usually use a sleep mask. I get to sleep easily unless reading, but after I wake to use the bathroom, I have trouble getting back to sleep. I was diagnosed with sleep apnea and was prescribed a CPAP machine. But a few years ago, my neurologist said I did not have apnea. I still like to use my CPAP, especially if weather changes. Do you have any comments about this?
So, yeah, it's actually funny somebody brings this up because with the advent of these weight loss drugs, I know this isn't immediately related to that, but I have a lot of patients who are losing weight and their apnea is significantly improving or resolving. And some of these patients still feel better on CPAP. They continue using their CPAP. Um, would I be able to explain why? Not necessarily. Sometimes there are certain disordered breathing events that can be caught in an in-lab study that are not caught on a home sleep test. So if a person had a home sleep test as a baseline that then confirmed no apnea later by repeat home sleep test, there could still be some residual apnea present that could be caught in the lab. As well as, I know this one sounds kind of silly, but you're getting filtered air, ideally 7 to 8 hours a night. And specific to a seasonal allergy perspective, it can improve how people feel with their seasonal allergies.
Frida would like to know if you wake up and can't seem to fall back asleep, is it better to get up and read by a low light or try to keep falling back asleep in bed?
There are two schools of thought on this one. So, therapists who practice cognitive behavioral therapy for insomnia or CBTI, which, by the way, is the first line treatment for insomnia, they will say if you're in bed more than 20 minutes and not able to get back to sleep, get out of the bed, go somewhere dimly lit, and do something, ideally not on your phone or TV. Reading, yes. Um, that is to help the brain not associate the bed with the frustration of not sleeping, because then that issue just kind of starts to compound and snowball. There's another school of thought, and I give patients the option of either of these. The other school of thought is if you're in bed and you're not particularly distressed, getting up and having that light exposure could interfere with melatonin production, and some providers will recommend listening as a tool. I have patients who listen to audiobooks sometimes, podcasts, something you're not emotionally invested in. And some people don't like listening to audiobooks because they lose their place. Music's an option. I have at least one patient who falls asleep to the dulcet tones of death metal. It works for them. So those are kind of the two schools of thought: avoiding light and staying in bed and listening, or getting out of bed. Yes, that is an option and recommended.
Another audience member would like to know what are useful sleep assistance meds, for example, melatonin, and not useful ones. So I don't know if you have any ones that you particularly or specifically would advise against not using.
Yes. So I that is the pharmacy of insomnia is like its very own talk, and I actually have a talk on that. But I'll try to answer as concisely as possible. Um, I always approach adding medication for sleep very carefully. Again, I don't like people to be on medication unless they have to be. And even then, usually I add sleep aids with the idea that somebody will eventually come off. I usually consider 6 months of well consolidated sleep the time frame for starting to reduce and discontinue those medications. So, what medications would I avoid? Um, you mentioned melatonin. Melatonin's fine over the counter. It's better for sleep onset insomnia, so getting to sleep at the beginning of the night. There are extended release formulations that may help with staying asleep. Um, and so far, the data is such that we still recommend it for those issues. The specific thing that I would like people to avoid is taking Unisom or doxylamine, Benadryl or diphenhydramine, excuse me, or any of the over-the-counter sleep aids that contain those antihistamines in them, because they are in a class of medications that have been associated with a significantly increased risk of dementia. Um, so if you take them daily or nightly for 3 or more years, the data shows that you could have an up to 54% increased risk of dementia. I do see some patients who have been taking Benadryl nightly for a long time, and they start to have cognitive complaints, and sometimes pulling the Benadryl can help. So it's good once or twice a week, but once you start having to reach for like Tylenol PM every single night, that's the time to start talking to a sleep medicine provider. That's the medication that I just want to highlight that I want people to avoid or use sparingly.
Thank you. I'm pretty sure that our audience members found that very helpful. We have two similar questions next. Where can I find an appointment to be tested for sleep apnea? And then Kathleen would like to know, how do we make an appointment with you?
Okay, to answer the first question, so it depends on how your primary care works. Some primary care providers are associated with groups that have a relationship with a home sleep test company, and they can order sleep studies and then refer you out once the results are back. Or your primary care can just simply refer you to a sleep medicine provider for a consultation, and then the sleep study can be ordered from there. And if you want to have an appointment with me, that's how you do it. So I'm in the neurology department, sleep medicine focused. I see patients at Sibley in DC and downtown Bethesda. And in order to get an appointment with our department, a referral is needed to adult sleep medicine. And then once that referral is sent over, or you send it over, then call us up and schedule an appointment. In terms of availability of sleep medicine visits, you may or may not know, like overall are pretty limited. I've been with Hopkins since October, and I tend to have a little more availability. So you might be able to get an appointment with me within like 3, 4 weeks, as opposed to waiting a while for other providers.
Connie asks, haven't natural sleep patterns been disrupted by modern life? In the
Oh, absolutely.
past, did,
Sorry.
in the past, didn't we sleep in two fragmented segments of 4 hours each, separated by 3 to 4 hours of wakefulness?
Got it. I am aware of the biphasic sleep cycle that you're describing, the two chunks of sleep interrupted. I will be frank, I don't know a whole lot about biphasic sleep. It is a topic that I need to look into more. But absolutely, modern technology and life has influenced our sleep schedules. I spoke about light earlier and it being like a drug that promotes wakefulness. Well, 200 years ago, we didn't have lamps shining in our face well into the night or TVs or phones. Additionally, a lot of cultures, had that afternoon kind of siesta time. And data has shown that eliminating that afternoon nap, I think in Greece, was associated with an increased risk of heart attacks and coronary artery disease. And so, absolutely, modern life has interrupted sleep, and just the stress of modern life makes it harder to get to sleep and stay asleep. Because if you're anxious, those are all very difficult.
Our next question comes from Dave. With age, he's now 74. I find myself sleeping more, totaling 9 to 10 hours. Is that problematic?
That's a good question. So there are, I thought about including this in the slideshow, but I ended up not. But too little sleep as well as too much sleep are both associated with health risks. And I would say that an adult sleeping 9+ hours, that's in the range of considering that increased health risk. So I would say that is something worth investigating. I mean, I don't know. I don't know your whole health picture, but it is worth looking into and seeing why.
What are your thoughts about Ambien?
Oh, Ambien. So, what are my thoughts on Ambien? Some of you may recall it's been used for decades at this point, and it used to be used more liberally. Um, it is useful, but in my opinion, for temporary use, because over time you can get used to it. Trying to decrease or come off of it can be difficult. And some patients have been on it for several years, and it was originally prescribed for something like staying asleep through the night when Ambien, for some people it can last longer, but it tends to help people get to sleep at the beginning of the night more. Um, so it has its uses, but I am very careful with that medication, especially in the 65 plus age group, because it carries increased risks of dizziness, falls. When you have somebody fall, they could break a hip, and then that just kind of spirals out of control in terms of health. As well as there is some data to suggest a dementia connection with the use of that class of drugs. We call them the Z drugs because the generic names all have the letter Z in them. Um, and that one's a little tough because also insomnia itself is a risk factor for dementia. But yeah, I use it sparingly, but I will use it every once in a while.
Could you speak a little more about central sleep apnea? I hadn't heard of it and would like to hear more how treatment differs or is similar with OSA. Thanks.
Right. So it's a lot less of my patient population who I see with this. Usually these patients end up with pulmonology, um, or the lung doctor. Um, but central sleep apnea, um, positive airway pressure is often the treatment. And a lot of those patients end up needing BiPAP therapy. So let me back up a second. CPAP, continuous positive airway pressure. The pressure you breathe in is the pressure you breathe out against, simplifying it extensively. BiPAP is you breathe in, the pressure is higher. When you breathe out, the machine detects that exhalation and the pressure is lower. That helps the brain not want to have as many central apneas. In fact, one of the issues some patients have with CPAP is something called treatment emergent central apnea, where the brain says, Well, if you're going to blow my nose full of this air, I'm not going to send the signal to breathe, and those patients end up needing BiPAP therapy. There's also a another type of machine that provides both positive airway pressure, but also is a bit of a ventilator as well. That one is mostly in the realm of pulmonology, although I do have maybe one or two patients on one of those types of machines. So sorry that I can't really expound more than that on the central apnea topic, but that's about my knowledge base on it.
I've been taking amitriptyline, 20 milligrams every night to help me sleep. Is it okay to take it for a long time?
Amitriptyline. It's not something I reach for right off the bat for people to sleep, but a lot of the older antidepressants are helpful with insomnia. In fact, doxepin in low doses, which is similarly an old antidepressant that by today's standards is not a great antidepressant, but in low doses keeps people asleep. Doxepin's actually FDA approved for it. I think the original question was long-term risks. Off the top of my head, let me think. It has some anticholinergic properties, which are the anticholinergic properties are the same thing um, that's responsible for some of that dementia risk with the Benadryl and Unisom medications. But I cannot recall if they've specifically tied the amitriptylines class of antidepressants with that long-term risk. It's something that if somebody needs to be on it in the long term, I'm okay with. Mostly patients end up having, with time, they have more side effects. So I mentioned anticholinergic. Those side effects tend to dry you out, basically. So dry mouth, dry eyes. People can have bladder issues and urinary retention. Those are more so reasons people end up stopping it in the long term. But it's also a good choice for patients who have insomnia as well as migraines. It's something that is used for migraine prophylaxis.
One of the members from our audience asked, has there been any new cleaning methods or solutions to assist with cleaning maintenance of the CPAP devices?
Okay, I love this topic because a lot of companies out there are making these ozone cleaners and they're trying to make you think that your CPAP machine is filthy and it's going to give you pneumonia and all of these things. The data shows that if you clean your CPAP supplies as the manufacturer recommends, which is basically wipe the outside of the machine, once a week, take the hose, run some warm soapy water through it. Soapy water being something without antibacterial or lotion chemicals in it, and hang it up to dry. And I think the recommendation now is to rinse the mask out daily. And if you wash out that water chamber, so I've, in my opinion, the part of the CPAP that tends to get the most nasty is that water chamber because it has it's a moist, warm environment in order to make the water vapor for the CPAP treatment. It has to be warm. So I think the recommendation is once weekly. I actually have patients take that water chamber and rinse it out every day and tent it open and let it dry. Because of all the bacterial and mold growth I've seen in CPAP machines, that's where it happens. All of that is sufficient to keep your CPAP clean. Eventually, those supplies get changed out, and you get new ones, and you start the cleaning process over again with the new stuff. You don't need an ozone cleaner. I'm aware that I actually was just made aware today from a patient that there's a CPAP soap available. It's like specifically for cleaning your CPAP stuff. I'm not aware that it's any better. I wish I'd have thought of it, but yeah. So you don't need the ozone cleaners. You don't need any special soaps or anything. Just the instructions that I gave and your manufacturer gives.
Grace would like to know what is the best position to sleep. For example, she's seen there are special pillows being advertised on television. So, what are your thoughts on sleep positions and then sleep pillows specifically?
Yeah, it's funny. I actually do get both of these questions a lot. The sleep pillow question is easy to answer. It's what pillow you are most comfortable with that doesn't cause any musculoskeletal pain, so neck pain, anything like that. The ideal sleep position, the most I can say about body position during sleep is that sleep apnea tends to be worse on the back. Gravity's working against you. The tongue falls to the back of the airway, makes the apnea worse usually. Um, And so there are actually some patients who have only sleep apnea or only have sleep apnea on their back, and training them in a side sleeping position treats the apnea. It's the least likely to hold in the long run. There's about a 5% continued side sleeping rate with that. But as we age, we tend to have joint pain and not want to sleep on our sides and gravitate to our back. I do realize that doesn't answer your original question of is there a better sleeping position? My best kind of shooting from the hip answer on that is whatever you're most comfortable with that does not exacerbate some of your other health issues, like joint issues or, migraines, things like that. Sorry, I don't have any better input than that.
What are the most common causes of chronic insomnia?
So this is one of those fields of sleep medicine where there are some unknowns. Um, some people, it appears that um, something in their wiring, in other words, the way their brain works, doesn't allow for consolidated good quality sleep, and we're not sure why. Um, as we come out with new classes of medications that treat insomnia, kind of the hope is we'll eventually figure out, if this medication works better for this class of people, maybe that's the pathway that's broken. So yeah, there are insomnias that tend to run in families. I often ask in consultation visits for insomnia, is anybody else in your family um, not sleeping through the night or tired in the daytime? Um, other back to kind of the topic is the most in my practice, I don't know broadly, but in my practice, one of the more common causes of chronic insomnia is actually obstructive sleep apnea. Again, I want to go back to the example of postmenopausal women where they're experiencing insomnia, they're tired in the daytime, and sometimes those symptoms get brushed off as just menopausal symptoms, and their apnea cooks for years and years and years. And similarly, that insomnia is present for years and years. And once you treat the apnea, oftentimes that insomnia falls into place. Sometimes I treat sleep apnea and people's insomnia remains. And you're more than welcome to have more than one sleep issue, and then we tackle the insomnia. But yeah, broadly, sleep apnea is the more common cause in my patient population.
Okay, we're winding down as far as time in the session, so we'll answer about 3 to 4 more questions. What treatment options are available for people who cannot tolerate CPAP therapy?
Yeah, it's a really good question. I would first say it depends on the degree of apnea present because severe sleep apnea and apnea with significant oxygen drops, I usually broadly that's oxygen drops into the mid to low 80s. Though the first line treatment for that especially is CPAP. Um, if a patient has mild to moderate apnea and their oxygen isn't dropping as much, dental appliances are an option. They'll correct they'll correct oxygen by about 3 to 4%. And the worse the apnea gets, the less effective they are. But I see them work for people frequently. I do refer them people out to have those made by sleep dentists. And then from there, I had discussed the weight loss, so I won't revisit that. But the hypoglossal nerve stimulators are an option as well. Um, what that entails, I didn't go into great detail about that, but it's a surgically implanted device. So, Inspire, for example, is implanted under the skin. It looks kind of like a pacemaker. There's a wire that's run up to one branch of the hypoglossal nerve. And that hypoglossal nerve is responsible for sticking the tongue forward. When you turn it on at nighttime, it makes the tongue stick forward, pulls the flesh off the airway, and helps treat the apnea. They're pretty effective. as long as the apnea isn't extremely severe. Most insurances require your BMI to be less than 32. I think Medicare's limit is 35. The FDA approval is for a BMI less than 40, but insurances like to push back on that. Otherwise, I do use combination therapies. If somebody is truly intolerant of CPAP, I sometimes I'll use a dental appliance in combination with training people not to sleep on their back. Maybe the apnea is much worse on the back, on the sides not as bad, and so if they stay on their side with the dental appliance, they do okay. Then you start talking about there are ear, nose, throat surgeries and interventions as well as um, small things like elevating the head of the bed that to I think it's 7.5 to 30 degrees in that range can chip away at the overall apnea present. So there are options. I try to work with people in around the intolerance issue. But I will point out that people who are intolerant of CPAP, if they try BiPAP therapy that I had talked about earlier, usually 80% of people tolerate BiPAP when they don't tolerate CPAP. So maybe a level up in therapy will be more comfortable, where you have that pressure back off when you exhale. Um, yeah. Oh yeah, yeah. And also I personally argue that a lot of patients get a CPAP thrown at them and they just kind of don't get a good follow-up. They just kind of get a full face mask and a CPAP machine and get told good luck. I'm really careful to follow up with patients in the first couple of months of them getting a CPAP machine because that's the golden period. That's when patients are most likely to kick it down the stairs if they have trouble. And I would argue that while online you'll see CPAP intolerance rates up to 30%, my personal rate would be much lower than that just because I really try to pay attention and help people through their intolerance issues.
Are wearable devices and sleep trackers accurate enough to monitor sleep health?
They are definitely getting better. So 10 years ago when these came out, they were not great. And I still had patients coming in with their data, like printouts of their data saying they're not sleeping well. And, you ask them their personal experience at night and they'll say, no, no, I guess I'm sleeping fine. They're getting better, certainly. There was a paper published either earlier this year or last year that kind of indicates they're good at identifying when you're asleep and when you're awake in the morning. The in between, what I tell patients is that if it aligns with your experience at nighttime, then it's probably accurate. And I know that's not the most helpful input, but at the end of the day, they're not FDA cleared for sleep staging. So, like Apple Watches, I think have like light, deep, and REM sleep, and patients will often get um, upset at the lack of REM sleep they're having. They're not FDA cleared, and they work by detecting movement. And so I find that just sometimes they're too sensitive to movement and tend to underrepresent the amount of deep and REM sleep.
Ladies and gentlemen, this concludes today's webinar. On behalf of the Community Health and Wellness team at Suburban Hospital, we sincerely thank you for joining us and extend our deepest gratitude to Ms. Carter for sharing her expertise today. We hope this discussion helps you make more informed choices regarding your health. As a reminder, please take a few moments to complete the survey that will appear at the end of the webinar. Your feedback is greatly appreciated and helps us improve future programs. Thank you again and have a wonderful rest of your afternoon.